Dear friends, okay, that's it. You are in the OR. Well settled in with your favorite assistant. You've got the drawing of the detachment by your side. You have made a conjunctival incision in both quadrants where you have to work, and you have passed 3 traction wires under the muscle at noon, 3 o'clock and 6 o'clock. You will now cryo these 2 tears. Maybe you will start with the tear at 4:30 for 2 reasons. First, because you want to make sure that, as you planned, you are not going to indent it. Indeed, you have noticed that when you scroll down the retina from front to back by exerting a scleral depression with your cryo probe, you are able to judge much better the usefulness of an indentation. It sometimes happens when the depression had just passed over the tear that the flap becomes horizontal, indicating that the vitreous traction is more active than expected, and that, on contrary to the preoperative feeling, it will be necessary to indent the tear. But you start with a 3:30 tear also because, as you are sure to indent the tear at 1:30, it is better to finish the cryo by it, because then you will not have to change position to locate it in the same time. Indeed, if you don't indent the tear at 4:30, you will not have to locate it. So you start with the 4:30 tear. Your assistant takes the 2 traction wires of 6 o'clock and 3 o'clock, one on each end, pulls them up and rotate them so that the 4:30 zone is brought to around 6 o'clock. You take the cryo probe with your dominant hand, the right hand, if you are right-handed of course, and you place the fibrillance over the eye with the other hand, putting the equator glass at noon. You are then going to make a movement which is capital and which will be useful to you each time a check for a tear is necessary, the scrolling of the retina. You are going to create a scleral depression, your index finger exerting a centripetal pressure on the cryo probe, which will be transmitted to the ball of the probe. This pressure on the ball will thus create an indentation at the level of the pars plana, and you will slowly lower your cryo from the pars plana to the equator. Then you will come back further forward and repeat this gesture by scrolling the retina millimeter by millimeter. Under the effect of this retinal mobilization, the dehiscences will appear either in red when they are flat on the indentation, or in dark when they are at the level of a detached retina behind the indentation, or finally in red under the effect of a retroillumination when they are located just beside the zone illuminated by the slit light. This examination will be done, of course, at the high magnification of the microscope, so you will not miss anything. It is important that you do this scrolling from front to back to match the neuroepithelium around the tear very exactly to its corresponding pigment epithelium. If you indent directly directly in front of a tear without taking care of this retinal scrolling, you could freeze an area of pigment epithelium posterior to the tear. In a pseudophakic patient where the PCO has made preoperative examination difficult, the indentation produced by the cryo will push the retina periphery into an area accessible to examination by the equatorial glass and allow the identification of and the treatment of tears that went unnoticed. The only difficulty with this fundamental gesture is that you will make this movement without being able to look at your hand, since your eyes are fixed in your eyepieces. You will only see your cryoprobe when you introduce it vertically between the episcleral tissue and the sclera. But afterwards, you will only see the intraocular effect produced by the scleral depression, and this requires one precaution. It is absolutely necessary to be careful not to insert the cryoprobe too much posterior, to be sure that it is the indentation created by the ball that you see appearing at the level of the pars plana and descending toward the equator. If you push the cryoprobe too posteriorly, the ball may be behind the equator. As you will not see a scleral depression, you will press harder and make a depression with the rod. Since the ball of ice does not freeze the tissue you are observing, you will insist and realize too late that you are freezing much more posterior zones, even the posterior pole. I thus advise you to place your finger on the handle of the cryo, also taking support on the head of the patient, always in the same way, in order to avoid this accident. On the good realization of this scrolling of the retina will depend all your insurance, all your certainty to have seen everything, and thus your capacity to limit the surgical trauma. But let's go back to our patient. So you are at 4:30 and you take care to place the small tear just on the top of the depression induced by your cryoprobe, so that the ball of ice freezes in one go the tear and a small safety zone all around. You know, in fact, that the expulsion of RP cells in the vitreous is only produced by the freezing of the previously treated area. This was easy because the tear was very small and you have confirmed that it was not subject to active vitreous traction and that it was therefore not essential to have it carried by a scleral indentation. You will now proceed to cryo for the tear at 1:30. To do this, the assistant will release the 6 o'clock traction wire to take the noon wire. He will then hold the 2 wires at noon and 3 o'clock and will turn the globe as a puppeteer can do to bring the 1:30 zone around noon. During the same time, you will have placed the equator glass at 6 o'clock and you will freeze, if possible in one go, the tear as seen previously. The only difference is that this time, this is the thumb that will exert a centripetal pressure on the handle of the cryoprobe. Sometimes the tear is too big to be frozen all at once. You will then slightly move the ball of your cryoprobe to freeze part of the tear with a small safety zone all around. Then you will move your cryoprobe to reduce the operation on the untreated part, trying not to come back to the previously treated areas. Sometimes the subretinal fluid is too abundant to obtain the contact between the tear and the indentation created by the bore. Then you have two solutions. The first is the Anglo-Saxon technique called DACE, drainage, air, cryo, and explant. This technique starts with the drainage of the subretinal fluid, the volume of which is immediately compensated by an intravitreal injection of air. Then, thanks to a wide field lens allowing to see through the air bubble, cryotherapy is performed with the localization of the tears, the procedure ending with the episcleral indentation. It is clever. If you choose this technique, I recommend that you take very precise marks of the tears in relation to the vessels, to pigmentary modification, all what you can find before doing your drainage injection of air, because through the bubble you will have difficulties to detect the small dehiscences. The second technique, which is the one I prefer, could be called DCBEDG. That is to say, drainage, cryo, BSS injection, explant, redrainage, and gas injection. The idea is not to change anything to the sequence of location, indentation, drainage, gas, but simply to allow the realization of the cryo thanks to a small trick. You will start by performing a self-sealing drainage in an avascular interverticus referee. I will explain you when we talk about the drainage technique, the how and why of this choice. To do this, the spatulated needle of the 80 Vicryl is inserted as an extremely oblique angle so that its intrascleral path is very long. The fluid starts to come out, but the needle is held in place so that half a cc or even 1 cc is evacuated. There is no risk in this kind of detachment sufficient bolus to prevent contact. There is most of the time more than 2 cc's of fluids under the retina. The needle is then removed and the sclera is pressed to close the puncture. It is then necessary to go very quickly to do the cryo and not to leave the eye in major hypotonia, source of complication. The cryo is done in the same condition of visibility as usual. Half a cc or even 1 cc of intravitreal BSS is injected to restore the IOP and allow the rest of the procedure to continue as it would have been done without the problem of contact with the cryo. That is to say, successively, location of the tear, episcleral implant indentation, drainage of what remains of subretinal fluid by performing another puncture, then gas injection. Here it is. I could talk for hours about all the clinical situations that could alter the cryogesters, but I'd rather stop here. Oh yeah, just one thing. As you have seen, I was careful not to repeat the cryo around the tear to avoid expelling too much RP cells. But when checking the existence or not of dehiscences, I did not hesitate to make a cryo diagnosis. In my mind, either it was indeed a dehiscence and then cryo was necessary, or the lesion was not open and then the RP cells could not pass through. So let's go back to our patient. You did the cryo of the tear at 1:30. You removed your cryo, and without changing anything, you will localize the tear. Your assistant has not moved. You took the Meyer-Schwickert marker, you slide it along the sclera, repeating the same movement as with the cryo probe. The tip of the marker is turned to the side and you depress the sclera with the ball of the marker. When you are in front of the tear, you turn your marker a quarter turn so that the point is on the sclera. At this point, while you maintain a very light pressure on the sclera, your assistant will perform a complex and important gesture. Take the 2 traction wires in one hand. Grasp the bone retractor in the other. Slide it between the conjunctiva and your marker without making you move. And gently pull the 2 wires into the quadrant opposite to the tear. You will follow the movement, and as the bone retractor remains in place, the sclera related to the tear will be perfectly exposed. You will only have to remove the marker, which leaves a black mark on the sclera. You can mark the top of the tear using diathermy or any other mean you want. You have done the retinopexy and the marking of the tear to be indented. All you have to do now is to indent the tear and then perform a drainage and gas injection. Let's first see how to make the indentation in the next chapter.